For me, it's all about the patients. I have had the honor of being a family medicine physician for 25 years, and I've been in the same practice after my training for 22, and I have been caring for the same families, and they have been caring for me. And our children are growing up together, and it is honestly, I do genuinely tear up. It is the joy of my life. This is one of my favorite families. They are actually from Gujarat. And they were actually inspired a model of care. And so I felt I wanted to honor them today with their permission, obviously. So for today, I think we want to go into why we are called upon to integrate mental health into primary care. Why make primary care the focus when, oh my goodness, the leadership that you have here is astonishing. And I already knew Dr. Nahida, but I had no idea the depth of your team. So it does, but it actually does make sense. And here is why. So this is actually a study from the chair-in-chief of Cambridge Health Alliance. Cambridge Health Alliance is a humble primary care and psychiatry network with a psychiatry hospital and 2 medical hospitals, that it's in the public sector, which is, I think, maybe hard to explain because the United States healthcare system is very complicated. But basically, what it means is anybody can get care and we can turn nobody away, which fits perfectly with how I would love to live my life. And so I never left. But what this slide shows, which is so important, is exactly what we heard from His Excellency, which is we have to go to where the people are. If you really want to help people, right? Part of our job as caregivers and clinicians and human beings is to listen to them deeply and go to do what they need when they need it. And they are actually not going to specialty mental health exactly for the reasons you heard. The stigma is tremendous. And so we can overcome this by simply listening more carefully to them. And so we have actually had at the Cambridge Health Alliance a philosophy, and this is part of the patient-centered medical home. Cambridge Health Alliance is one of the leaders in the patient-centered medical home movement, interestingly, but when you're small and mighty, you can get a lot done. And what we've designed is what's called a step model of care, which basically says a lot of people are actually not in need of a lot of specialty mental health. And we had made the same mistake the world made, which is having very specialized, amazing clinicians, but actually the majority of people didn't need that. They actually needed something much simpler. So step 0 resides entirely in primary care, and I'm very comfortable doing that, as are all primary care people. Step 1 resides in primary care, and it has consultation that occurs at the site, so that the person does not feel the stigma. The person knows that they're coming for an appointment like they'd come for any appointment, and they can get the care they need. And we can frame that to them as an essential part of taking care of themselves without having to make them feel like there's something wrong with them. Because that's what happens, right? When people say, I'm not okay, the me inside the body is not okay. And we don't have to do that. They will do that on their own time, just like this beautiful person that was able to post his video, and good for him for taking care of himself to take it down again. So then step 2 is actually having the therapy for people who do really identify that they need therapy, also within a safe space. Part of our job as primary care is to create a space where people feel loved. They feel safe, they walk in the door, they know the receptionist, they know the nurse, they know the doctor, and they know that they're going to be cared for. And so that is a good place for that, is still in that safe place, because if you're going to be making yourself vulnerable, which is what we do when we seek mental health services, you want to be doing that from a place of comfort. And then step 3 and 4 are really quite complex mental health issues. And those really do belong in specialty mental health. And I have some interesting stories about how even when you plan things so beautifully, they don't always work out that way. So we have, and please just look at this as a model for adaptation, but what's worked for us is we actually have someone who is a care partner, which is an unlicensed mental health resource. And I actually was thinking about this conference last week because I had a patient come in and say, I do not want a therapist. He has disabling anxiety. He could do pretty well with a therapist. He does not want a therapist. And I was like, that's absolutely fine. We have someone who is not a therapist. And that is this trained mental health clinician who is not licensed. And the care partner, and it's Isaiah, who's amazing. And Isaiah, as I was like, oh, Isaiah, we'll just talk to you. You can download some apps. It'll be great, right? You go to whatever the patient needs. We also have therapists, and then we have a little tiny dose of doctor, right? We don't need a lot of psychiatry, it turns out. So, which is great because we don't have a lot of psychiatrists. I don't know anywhere in the world where we have enough psychiatrists. So we're no different than anyone else. And they are actually very much like primary care doctors are now, where they're leading the team. And so you can have these wonderful people that are able to do the majority of the work, and you get the very specialized, very advanced training at a very small dose. So I'm going to go through this. I'm just going to leave this here, but of course you have a copy of the slides, I hope. Absolutely, please feel free to also reach out to me in the future. But really what you see is that this is a model for primary care that looks like everything else we do. So from the primary care perspective, integrating mental health is just like using any other extended team member. So the patient is at the center. You can see the big blue circles are the primary care provider at the bottom, and then the nurse. We have medical assistants who are the person who takes you from the waiting room in and actually does a lot of population health. And then we also have our practice medical receptionists, which we feel very strongly also need to be part of the team and need to be professionalized. So our practice medical receptionists actually have, they understand patient privacy, and they're considered an equal member of the team because people, it's a fascinating conversation I can't get into right now, but let's talk about receptionists if you have any interest in this. It's really interesting what we found by doing this. The power of this is that we really do need to look at the population, right? Just like we heard, but we need to look at it within the clinic. And that's actually like another job on top of our job, which has been very difficult. And that is the inspiration for the patient-centered medical home movement. So what we've done is identify the work, break it down, find the team, and do the work in team. And that is how we've managed to integrate population health into primary care. So population screening, everybody every year gets screened for mental health and wellness. If a problem is identified, we actually do a brief intervention. And if needed, we can refer to treatment. So in more detail, we have a brief screen. If that's negative, you don't need to do anything. If it's positive, you do a brief assessment. And then you figure out what to do using the team you have available. And remember, our team now has a care partner, a therapist, and a psychiatrist. Amazing, absolutely amazing. So the phases of care for depression, as we know, this is a deadly disease. And again, as primary care, I view depression the way I view diabetes, the way I view hypertension. It is a chronic relapsing disease that needs management. I think there's relatively little emotion now that we have help for this. What our journey was as primary care before we had this help integrated into our clinic was actually the inability for us to know what to do when we know we are not the solution. And that we are all very familiar with that right now from COVID, aren't we? Right? We know that we're supposed to be helping, and then there's actually nothing we can do, but we're the only plan. That is a very destructive feeling, and primary care has had a lot of trouble with burnout and a lot of trouble without the adequate services to be able to help the people in front of you. And honestly, really, truly, of all of the extended team members that I have, the last one I will give up is mental health. That is the last one to go. You could maybe even take a hand before I would let mental health go, because I don't want to go back to where I felt helpless and I felt depressed myself and I didn't have anyone to turn to. And so you bring the patient back over and over, but you're not really trained to know what to do. And then you and the patient kind of go down this spiral together. No reason to do that, guys. There's a better way, and you're about to start it. And I genuinely am just so elated by being able to share this work and say that the future, which is what you were talking about, genuinely is better than where we are now. I would never go back. So this particular talk has got a lot of details. They're fun, but I'm going to skip through them. We mentioned addictions in the United States right now. This is actually a hidden epidemic, and it's extremely destructive to our young people. And so we did what we always do at Cambridge Health Alliance. We looked at our population, and then looked at the data and divided it and then figured out what to do. So what happens, interestingly, with addictions is that they don't come into primary care either. So they're really hard to find. And that's, I think, the thing that's the most scary is that you don't know where to even go and find them. So what we've done is exactly what it's amazing. I just am so inspired by being here with this group of people. You want to prevent it. You don't want to let it get to the point where they're going to the emergency room and using the substance and they're self-destructive, and you might not be able to change the course at that point. So we screen everybody. We screen children, we screen adults, we screen everyone for everything at this point, because we can. When I screen you, I have to have a solution. I have to have an approach. I have to have something to offer you. I have that now. I have that now, even for addiction. So we do a brief intervention, and then we have actually this tremendous workflow. There's always someone to help. I'm so elated by even being able to say that, right? That feels like I can go on being a primary care doctor forever. Because the things that were so difficult for me are now completely resolved. We do have process measures. We are nerds, we are still doctors, and psychologists also love this. And so we share the responsibility. We work as a team. We are really one now, and we support each other. When someone comes in, and I was just talking to Dr. Khan about this earlier today. I had the joy of seeing your family medicine residency site, and it's beautiful, and also we have amazing leadership there as well. So this is the support for me when someone comes in or someone's after hours and I don't know what to do. Happens all the time, guys, right? And I'm old. You'd think I'd know something by now, but people are complicated, it turns out. So I need wonderful humans like Dr. Wong, who is featured in all of these pictures. He is also one of the primary architects of this at Cambridge Health Alliance. We are a bunch of activists at Cambridge Health Alliance. We all carry Suboxone. We all carry naloxone with us. We've actually had to use it, which is very sad. And we all prescribe Suboxone. Suboxone is a miracle drug. It is absolutely amazing. I'm so humbled by seeing people that I had thought were lost become themselves again. And honestly, it's a joy. It is very painful if you follow people through their life cycle. If you know them as children and then you watch them enter addiction, it's like I have 200 children, right? I mean, it really tears me up inside. So to be able to offer something that's actually life-saving, it's like insulin for people with type 1 diabetes. It really is amazing. All right, super quickly, ready? Turn around. Let's do this the other way. So what happens if we don't put psychiatry in primary care? We put primary care and psychiatry also, not or, and. Why? Remember I talked about the stage 3-4 people and I said, it's a great, on paper, 0, 1, 2, 3, 4 looks great. Well, it turns out when you feel love and you have a severe mental illness, you just keep going back to the place that you feel loved. So the step 3-4 people just keep coming in and they don't go to their specialty psychiatry appointments because they don't feel loved there yet, right? And so you can put it on paper, but it didn't actually work. So what we realized is we need to bring that love into the place that they really do need to be. People with schizophrenia, people with disorganized thinking, they actually don't navigate primary care really well. It's actually hard for them to have little children running around, right? And they see the world differently. So it's a wonderful privilege to be able to be at a place where we're able to do both. And so you're going to hear later actually about the health integration program. And this is one of the programs it's been a joy for me to work with. And we're also starting to put primary care within psychiatry. My primary care site is actually at the specialty psychiatry center. And so a couple of my physicians who have just found their love treating severely mentally ill are going to be helping found that. And there's Dr. Elizabeth Davis is also an amazing leader at CHA who is leading this. So what is a behavioral health home? I think everybody here, I feel like you'd know the why, but just in case, it's shocking to me how much earlier people with severe mental illness die, and I can understand it. It takes a lot of the same skill set that we use in primary care, a lot of care coordination, a lot of patients, a lot of visits, and that's all for the good. Our target population for our health integration program was exactly those people I described. It's been transformative. It's amazing the treatments that we have, but you have to organize their care as well, or they can't get the treatment because they're disorganized. That is actually exactly what you're treating. So these new team members, for them, look a lot like primary care. This looks exactly like what I just told you, but this is psychiatry. And this is what it's looking like more and more. This is such a beautiful picture, right? And you know what it looks like when you put these pictures together. You're like, and I'm going to put a circle here and I'm going to put a box there. And then you sort of, there's only sort of boxes, right? But actually we're pretty close. It's been a while, but we're getting there. So this is my clinic. It's not beautiful, but that's okay. It's beautiful on the inside. And we actually, again, psychiatry is embracing the measures just like primary care, because if you don't measure, how do you know if you're helping anyone? It's one way. You can know personally, you know, your heart knows, but you also do want to be able to point to people that would be able to fund these kind of programs and say, actually, you know, those terrible mortality gaps, we can eliminate those. So dashboards are one way to measure in a way that's not painful. We've integrated them. Communicating, when you have teams and you form teams, you need to communicate across the teams. That's one of those fundamental precepts of patient-centered medical home and integrating population health into care. And we actually now all know when people are in distress, the entire team gets an alert, which is wonderful, and we work together. We have we're still working on the hospital care transitions, right? People that are severely ill and wind up in the hospital. Dr. Khan is nodding, right? It's very challenging to get them back into care. And I actually am not totally sure why. I would love to talk to people about that because I don't think we figured it out. But it's one of those things that keeps us all engaged in this work. Again, break down the work, find your team, and help address the problem. So the thing that allows us, again, you touched on community, and this is near and dear to my heart. One of the things that allows us to go into the community, to leave our walls and go again to where people are, just like we want to go to where people are with psychiatric services for primary care, we need to actually go into the community, because health is actually what we do all day, every day. It's not a 20-minute medical visit once a year, maybe even 3 times a year. It's not going to help. So what we did is we actually were able to find a community partner for when we had 4 suicides in a very short period of time from a very vulnerable community. We were able to join together with the community organization, psychiatry and primary care, and form an intervention that now, because this is before COVID, now we would do it all. It would all be on social media, and it would be so much more powerful. I'm so inspired by what you've done. This is one of my favorite ways to practice care. O meu bebê lindo. I speak a lot of other languages because that's who comes in the clinic, and I love to speak languages. And so this is actually a Brazilian empowerment group that was supposedly to do the well visits for babies, but of course, really what it was also trying to make sure that these young women did not feel socially isolated, depressed, and vulnerable. And so another way to prevent something as terrifying as suicide is to create community. And this is one of the ways we're now free to do that, because I have that energy. I'm back, right? I'm able to do the things I want to do. I'm not feeling the weight of the world on me the way so many primary care providers describe. So all of this comes to some silly little graphic I put together, right? I talk a lot about love, I do mean it. And I understand the need for the importance and need of integrating a holistic approach and making people feel like they're at home when they're actually in our care. And I thank you very much.